I welcome you all to our expert discussion today on the unmet needs of late-onset genetic cholestasis. I'm happy to be here today with two of my esteemed colleagues, Silvia Vilarinho and Deepak Joshi, and we will tell you a little bit about the unmet needs from our point of view. So I will start on the clinical presentation of patients with late-onset genetic cholestasis and how you might diagnose those patients. So why are we doing this? Because despite extensive workup, about 14 to 30% of adult liver disease remain of unidentified etiology, albeit we've done what we think almost everything. And if we then use genetics, we can explain the clinical phenotype in about 30 to 50% of these cases. So unfortunately, not all of them, but about half of them. So what I want to tell you today is the spectrum of genetic cholestatic diseases and how they can present clinically. When should you think about genetics in adults? And we will later take on with Silvia and also Deepak therapeutic and management approaches in these patients. So if we think about cholestasis, we have to think about that it's not only the biliary tract that is affected, but also the hepatocyte. So what you see here is two adjacent hepatocytes with BSAP, which is the bile acid transporter, and MDR3, which is the phospholipid floppase, and they secrete bile acids and phospholipids into bile, which then flows through the bile ducts into the small intestine, where the bile acids are reabsorbed. So what happens in genetic cholestasis, and the majority of these cases somehow affect the transport activity of the bile salt export pump BSAP. We don't have sufficient bile acid excretion into bile, meaning the bile acids accumulate within the hepatocyte, which I depicted in green here. And this means that we have damage at the site of the hepatocyte because high levels of bile acids are cytotoxic. So this results in high serum bile acids, and this also results in high serum levels of ALT and AST because the damage is at the site of the hepatocyte. Now, if we look at bile, we have low levels or no levels of bile acids, but we still have phospholipids. So the cholangiocyte is actually the happy cell in this scenario, and this is the reason why we don't see an elevation of gamma GT in this. And if you think about genetic cholestasis, the prototype of these cholestasis subtypes, which we call primary failure to secrete bile acids into bile, is the ABCB11 or BSAP disease. But the majority of the other genes that we identified as cholestasis related actually do impair BSAP function and therefore lead to a very similar hepatitis-like presentation of cholestasis. And this is something that we forget in the adult population. If we think about cholestasis in our guidelines, it's always elevated ALP and gamma GT, but we are missing this portion of patients that actually have a hepatitis-like picture as in this primary or secondary failure to secrete bile acids. So if we look at the other scenario, in this scenario, you have an intact BSAP function, but for example, MDR3 is not working fully, then you are missing the phospholipids in bile. And now the hepatocyte is not the site of damage, but it's the cholangiocyte. And now in these patients, you actually get the elevation of the gamma GT. There may still be elevation of ALT, AST, and also serum bile acids because the canalicular membrane here between those two hepatocytes is also affected by this bile. So we have to distinguish these two types, and the prototype of this cholangiopathy, like intrahepatic cholestasis, is the ABCB4 or MDR3 disease, but there's other genes that lead to a very similar picture. Now, if you think about these patients in your clinical workup, the majority will present like hepatitis with elevated transaminases, normal gamma GT, and raised serum bile acids. So in the adult population, we would always take the history, do the physical examination, do an ultrasound to see if there's already signs of progressive liver disease, and then we would rule out the most common causes of elevated transaminases, for example, viral hepatitis, ALD, meta-ALD, or MASL. If we then don't find an answer, we continue to go onto liver biopsy, and I always go onto genetics at this time point. And I also think about genetics if I have a patient with insufficient treatment response where I thought I had the correct diagnosis, but then it gets somehow unexpected. If we think about the second scenario, so those patients presenting with elevated gamma GT, maybe also elevated alkaline phosphatase, and more like a cholangiopathy, we do the same workup, but now the differential diagnosis is the cholangiopathy. So we rule out common cholangiopathies like PBC, PSC, other causes of sclerosing cholangitis. We normally perform an MRI and MRCP. And again, if we can't find a solution, then we go to liver biopsy and genetics. As we are talking about genetic liver disease, are there cases where I do genetics much more early? Yes, there are. And those are commonly those families or patients presenting with a very clear history that is highly suggestive of a genetic hereditary cholestasis. And those patients we will talk about in the second two talks again. So the question I always ask is the clinical phenotype highly suggestive of genetic cholestasis? And if you do genetics, is the genetic finding sufficient to explain the phenotype in your patient? Because if not, please dig deeper. We might have overlooked something. So to give you an example, this is a patient in his 50s. He presented to our ER in June with his second episode of jaundice and itch after antibiotic treatment within the last 7 days. He had a normal fibroscan on presentation, and he had a biopsy a month later because things didn't get better, and it showed acute cholestasis and toxic damage. The MRI showed no signs of a cause, and he had a past medical history very similar 7 years ago with itch and jaundice, and he had a liver biopsy 7 years ago, which did not show any cause of this jaundice episode. After taking prednisone at that time, because the jaundice continued for 3 months, he was symptom-free and had normal liver values over the past 7 years. So our working hypothesis was actually drug-induced cholestatic liver injury. So if we look at the lab values of this patient, on the top you will see bile acids and bilirubin, and on the bottom level the transaminases, and I depicted them as x-fold the upper limit of normal. You see that the patient actually has very high bilirubin levels. They are up to the 30 times of the upper limit of normal, and he also has serum bile acid levels the 30 times the upper limit of normal. The transaminases, which were really high at the beginning, actually reduced by themselves, and as you see here, gamma GT was even normal. Because of his severe pruritus, we started with a bile acid sequestrant. As it didn't work, we gave him a fibrate. Again, it didn't work. We started him on urso because of the high bilirubin, and we also started him on a steroid because it had helped 7 years prior. But it didn't really show us what's going on. And if you have bile acids the 30 times the upper limit of normal, we thought we can't go on like this, so we went for genetic analysis. And we also repeated the fibroscan, which now increased to 23. So the genetic workup, which was actually quite successful, it showed a heterozygous ABCB11 BSEP variant, which is truncating. And because of that, we actually started this patient on an IBAT inhibitor. And what you see, as the prednisone started to lower his bilirubin levels, the IBAT inhibitor started to lower his serum bile acids, and the patient is now symptom-free. And we did have a flare in his transaminases and gamma GT, but these are all going back as well and returning to normal. So the question might be, why did we do a genetic workup in a DILI patient? Because his bile acids were 30 times the upper limit of normal. Why do we believe that his genetics explain the phenotype? Well, the serum bile acids and a non-functional BSEP on one allele do really fit together. And this is the reason we did start an IBAT inhibitor, because we also had the increase in the fibroscan. So we thought, okay, this is getting progressive if we don't do anything. And how we did proceed, now that everything's better, we actually halved his dose. So there was at ASLD this year also a poster regarding BSEP disease and drug-induced cholestasis. And they looked at patients that had anabolic steroid-induced DILI and presented with severe jaundice and pruritus. And they actually found 93 male patients, and they performed a whole exome sequencing on those and compared them to over 900 controls. And very interesting, they showed a Manhattan plot, which showed a very high association with ABCB11, meaning BSAP. So there seems to be a good correlation of rare BSAP variants with drug-induced liver injury, especially for the anabolic steroids. And they also found more common variants in these patients, and that was highly significant as compared to the control cohorts, very similar as in what we observed with our patient. So DILI, especially with high serum bile acids and or prolonged jaundice, could mean that there could be underlying genetic disease, which you might find if you do a genetic workup. I also want to show you a second patient. This is a female patient now. She's in very good health, and she had her first episode of pruritus and jaundice at the age of 16. She had elevated liver enzymes at that time point, and she had gallstones and underwent a cholecystectomy at this young age as well. Since her cholecystectomy, she had 3 episodes of cholelithiasis requiring endoscopic stone removal until somebody put her on urso in 2021. So when I met her, her family tree, actually, she is the lady with the gallstones in blue here, denoted as ALPAC. She has a family history of gallstones. She also has a family history of cholangiocarcinoma. And there's people in her family tree that I put in gray because, in my opinion, these should be carriers, but I don't have any information on these persons. And if we look at her serum LFTs at my outpatient clinic, they were completely normal. She had only slightly elevated bile acids, and she had a normal ultrasound and FibroScan. So do we need genetics to confirm the diagnosis of ALPAC in these patients? This is actually a clinical diagnosis, so we do not need this. Would you do genetics in these patients? Well, I'm sure my 2 experts agree we actually would, and I did. And they both know what I found. I found an ABCB4 heterozygous pathogenic variant. And the question is, if we do find this variant, we have this history and we have these values, do I still need to do the genetic workup for the cholangiopathy? Because before she was put on urso, she actually did have a gamma GT. And I didn't do the full genetic workup because everything normalized under urso. But if she would raise her values or they wouldn't return to normal, I would look a little bit deeper to not overlook something else. So just as a short reminder, what is ALPAC syndrome? It's the abbreviation for the low phospholipid associated cholelithiasis syndrome. It's a clinical diagnosis. You need 2 out of 3. The age at symptom onset, meaning biliary colic below the age of 40, recurrence of symptoms after cholecystectomy, and intrahepatic micro or macrolithiasis. And this is actually not uncommon. The French cohort, which is the largest in the world, found that 1% of symptomatic gallstone disease patients entering a hospital actually fulfill this criteria. The majority is female. The onset is at young age, below the age of 30. And why should you look for these patients? Because in those families, there seems to be an elevated risk of hepatobiliary malignancy, and about half of these patients from these cohorts carry disease-associated variants in ABCB4. And if you look at these patients on an ultrasound, I brought you an ultrasound of one of my patients, you can actually find the microlithiasis, you find those stones and you think, oh, this must actually be the portal vein, but it's actually the bile duct and it's wider because of those stones. And so these patients with the variants in ABCB4, they have elevated gamma GT, they have common bile duct stones, and they may have a risk of cholangiocarcinoma. This is retrospective data, but we still would suggest that you follow these patients to detect this early. And there was actually a poster on a preclinical study, which I found very interesting at EASL. They looked at a small molecule that enhances BSAP as well as MDR3 protein levels. And in a cell culture model from mice and humans, they found more functional activity. And I think it will be very interesting to see what this substance brings in the future, if this could be something which we could use in our patients to target the liver and the protein levels directly and correct for these even milder phenotypes in the adults. And with that, I'm at the end of my presentation. I would like to summarize. Late-onset genetic cholestasis may present as cholangiopathy. This is what we would expect according to how we were taught, but it can also present as hepatitis, and this is actually the majority of the genetic cases. We should consider a genetic workup always if things don't add up. For example, you have high serum bile acids and you have a normal or low gamma GT, and also if patients fail treatment despite high compliance in their treatment. We always should ask ourselves if the genetics really explain the presentation of our patient. If not, please don't overlook anything else we could find, so please keep digging. And Silvia will show a case that illustrates that you should always talk to your geneticist. A second look might help. And as you might have heard, there is more genes coming, so it might make sense to also look at the genetics again 12 months later if you didn't find anything. The genetics may help you find a diagnosis earlier, and they may also offer you additional treatment options. And we must say genetics do not solve all our problems. There might still be unexplained phenotypes. In the adult population, we find many variants of unknown significance, and it's sometimes difficult, and I'm sure my colleagues agree, to then decide, is this it, or should we look for something else? And we should include these patients into prospective registry, for example, to look at the cancer risk, and also in clinical trials to offer them something in the future. And with that, I'm at the end, and I would like to open this presentation for discussion with my two colleagues.
Thank you, Verena. That was wonderful, actually. I think one of the questions I have, and I imagine a lot of our colleagues have, is when do you think we should perform genetic testing in patients with DILI? We see DILI quite frequently in hepatology practice. You show the case where that was really instrumental, and the patient, I think, because of your workup, did very well. So what are your thoughts if we want to bring that to more routine hepatology practice?
Well, I wouldn't do it in the emergency room, and I actually didn't do it in the first 2 weeks, to be honest, because I thought, okay, this will pass, he will get better. And as you might have seen, the bile acid levels were not stably collected. We did some at the beginning because he was really itchy, then we took a break in looking at bile acid levels, and then we did it again. And in his case, it was the really high serum bile acid levels that led me to go for the genetics, because 30 times the upper limit of normal, especially when the transaminases more or less normalized, his gamma GT normalized spontaneously, then something's not adding up. And that was the time point. We went for the genetics, and as you know, it takes some time. So we tried a number of treatments, as you saw. We can't account any of our treatments for the spontaneous recovery of the transaminases. I must say that happened more or less by himself. But I think we did really good on his symptoms with the pruritus, the itch, and the normalization. And he actually looks much, much healthier. He can eat better now. And his fibrous again is actually going down. It's not back to normal yet, but it's going down. So for me, it's the combination. I wouldn't go for genetics in every patient. As many of you, we did a series of 30 patients, and in the majority, you probably only find common variants. But those that have a feature that is more than what you see after an antibiotic, I would go for it, and especially if the patient is young. Deepak, what do you think?
Yeah, no, I was going to say, Verena, really nice presentation. Thank you. I completely agree. I think it's the monitoring of the patient. I don't think you can perform genetics in every single patient who has a potential drug-induced liver injury, but performing bile acids, watching their trajectory, and if it's failing to settle, and we sort of then need to start thinking about performing genetics to get additional information, but then potentially offering new therapeutics as well in terms of IBAT inhibition, which may potentially help the patient. Can I just ask, you presented very nicely, going through history, your algorithm, liver biopsy, genetics. Family history, do you also go through pregnancy history in women who've had previous pregnancies as well? Do you ask specifically about symptoms in those pregnancies? Is that helpful, do you think?
Yeah, well, I actually do it despite Silvia's paper, which showed that family history doesn't really help. But I actually ask everybody about the gallstone disease because, as you know, ABCB4 is my favorite gene. And I'm looking into a lot of cholestasis of pregnancy cases. So I actually always ask them. And I also ask for cholangiocarcinoma, as you saw in this one patient. And I'm really worried about this. And this is also because of this French data, and there's data from Amsterdam as well. In their cohort, there was also a higher rate. This is why we put into the European guideline, similar to PSC, that you should consider a patient with a pathogenic ABCB4 variant to look into once a year for cholangiocarcinoma screening, maybe use ultrasound, just to offer them some sort of follow-up until we determine in a prospective cohort if this risk is really, as high as we fear.
I would like to add, just because of Verena's comment, I always ask for family history as well, and I highly support that everyone should ask. And again, with gallstones, ICP, cholangiocarcinoma on the same family, like it was shown here, I think that also makes it think about ABCB4 a little bit higher than other genes. But what I also found just by doing genetic testing in patients with undiagnosed disease is that people with no family history, you will find a very similar yields of genetic testing. So I think that's kind of more the teaching point, is that we always think from medical school, if there is no family history, maybe genetics should not be in the equation. And I think data, and hopefully more data will come up saying, no, it's still as likely to find the genetic testing as it is if they have family history. So thank you.
Yeah, I agree. And what I found interesting, I don't know what you two thought about the ASLD poster on the anabolic steroid-induced jaundice and pruritus. I always thought this is purely MRP2, the anabolic steroids inhibit MRP2, and so you are jaundice, well, you probably don't hitch. And I would not have expected this really high hit rate in the rare ABCB11 variants. So this will, I'll probably do more bile acids now in the anabolic steroid DILIs, and I may have a look there as well. I didn't really in the past go for genetics in those clientele, because for me this was always clear this is an MRP2 substrate and it inhibits MRP2 transport.
Yeah, no, I agree with your comment, Verena. I think I found that poster very interesting. A group which I've not seen a lot of, but again, just thinking about performing bile acids and then considering sort of genetic testing in this group of patients as well. So yeah, I thought that was very interesting data.
This also gives me to think about how many or several times that I saw patients in my clinic because they were teenagers actually starting on OCP, so in the birth control containing estrogens, and many times is with that, we can say DILI, or that drug insult that actually ABCB4 mutation actually presents in that patient. So I think it also, if we look at in different ways, it's kind of how many times the drug is really revealing the genetic phenotype.
Yeah, I actually asked for that as well. If something happens after they started on a contraceptive pill,